If you have been told you have PCOS and sent home with birth control pills and nothing else, this video is for you. Because PCOS is one of the most mismanaged conditions I see in my practice. And today I am going to tell you exactly what's really happening in your body, what the long-term stakes are if it goes untreated, and what actually works. I am Dr. Doeun Lee, board-certified endocrinologist. I have been treating polycystic ovarian syndrome for over 25 years, and I want to give you the real picture, not the oversimplified version. PCOS affects up to 1 in 8 women of reproductive age. It is one of the most common hormonal conditions that exists, and one of the most undertreated. PCOS stands for polycystic ovarian syndrome, but despite its name, it's not really about cysts on your ovaries. It is primarily a metabolic and hormonal disorder, one that affects your period, your skin, your weight, and your fertility, and even your mood. The 3 defining features are irregular cycle, elevated androgens, meaning male hormones like testosterone, DHEA, and polycystic appearing ovaries on ultrasound. You only need 2 of the 3 to be diagnosed. This is called Rotterdam criteria. But underneath all of that, the driving force in most women is insulin resistance. Your cells stop responding to insulin properly, so your pancreas pumps out even more. That excess insulin signals your ovaries to produce even more testosterone. And that's where the symptoms come from. Acne, the hair loss on your scalp, the excess hair on your face and body, the irregular cycle, and the weight gain around the belly. One important thing to know, polycystic ovarian syndrome is not your fault. It is not caused by anything you did or didn't do. It has a strong genetic component. It runs in families, and it involves a complex interplay of hormones, insulin signaling, and inflammation that you did not choose. So why does it matter beyond irregular cycles and an unwanted hair? Because untreated insulin resistance in PCOS doesn't stay still. It progresses, and the downstream consequences are serious. The most well-established risk is type 2 diabetes. Women with polycystic ovarian syndrome have up to 4 times the risk of developing type 2 diabetes compared to women without it. Approximately 30 to 35% of women with PCOS already have prediabetes. They just haven't been tested for it. Cardiovascular disease is the one I want every PCOS patient to understand. Chronic hyperinsulinemia, chronically elevated high insulin level, drives dyslipidemia, abnormal lipid panel, specifically elevated triglyceride, low HDL, small dense LDL particle. Combined with hypertension and chronic low-grade inflammation, women with PCOS have significantly elevated atherosclerotic cardiovascular disease risk. This is a heart disease conversation, not just gynecology conversation. There's also endometrial cancer risk. When cycles are irregular or absent, the uterine lining doesn't shed properly. Chronic unopposed estrogen exposure without progesterone can drive endometrial hyperplasia and over time increase the risk of endometrial cancer. Sleep apnea is another risk that often goes underdiagnosed or unrecognized in PCOS, particularly in women with obesity. If you're waking up unrefreshed, snoring, or feeling excessively tired during day, bring this up with your doctor. And infertility. Because anovulation is common in PCOS, many women struggle to conceive. The good news is that when insulin resistance is treated, ovulation often improves, sometimes dramatically, without aggressive intervention. This is why I tell my patients, PCOS is not just a cosmetic problem or a period problem. It is a lifelong metabolic condition that requires active management. The earlier you address the insulin resistance, the more of this you can prevent. Here's something that most women with PCOS have never been told. PCOS does not end at menopause. The reproductive symptoms go away, period stops, cycle irregularity resolves, but the metabolic dysfunction underneath that persists. And in many ways, menopause actually makes matters worse. Estrogen has a protective effect on insulin sensitivity and cardiovascular risk. When estrogen drops at menopause, women with PCOS lose that protection on top of an already compromised metabolic baseline. Their cardiovascular risk accelerates, their visceral adiposity tends to increase, and the dyslipidemia that already present often worsens. This is why I see postmenopausal women in my practice who are told their PCOS is gone, and yet they have metabolic syndrome, elevated cardiovascular risk, and nobody ever connected back to their decades of untreated insulin resistance. PCOS shaped their metabolic trajectory for life. Menopause just removed the mask. Now, here is the good news. And I want to be clear about this. because PCOS can feel overwhelming. When you treat the insulin resistance early and consistently, the benefits compound over time in a way that's genuinely remarkable. Cardiovascular risk comes down, lipid panels improve, blood pressure stabilizes, the chronic low-grade inflammation that drives atherosclerosis starts to quiet. Women who address their insulin resistance in their 20s and 30s arrive at menopause in a fundamentally different metabolic position than women who don't. Fertility improves, often without IVF. Regular ovulation returns in many women when insulin signaling is restored. Endometrial cancer risk decreases because cycles regularize and the uterine lining sheds properly. Type 2 diabetes risk drops significantly, and women who are already pre-diabetic, metabolic intervention can reverse that trajectory entirely. And perhaps most importantly, how you feel day to day improves. Energy, mood, weight, and skin all respond when the root cause is being addressed rather than masked. PCOS is a chronic condition, but it's one where the effort you put in early pays dividends for decades. That's the message I want every woman with PCOS to leave this video with. Birth control pills can regulate your period and lower androgen symptoms, but they do nothing for the underlying insulin resistance. So the root cause continues to be untreated. This is why so many women with PCOS feel like nothing is really working, and why the long-term risks I just described keep accumulating silently in the background. What actually needs to happen is addressing the metabolic component, and that means lifestyle and sometimes medication. Here's what I do in my practice. First, lifestyle. And I want to be specific about this because telling someone to just eat less, move more is not a treatment plan. There is no single proven PCOS diet. What the evidence supports is a balanced, sustainable eating pattern that reduces glycemic load, meaning fewer refined carbohydrates and added sugar, combined with at least about 150 minutes of moderate physical activity per week. Even a 5 to 10% reduction in body weight in women where weight is a factor can significantly improve cycle regularity, androgen levels, and insulin sensitivity. The goal is building sustainable habits, not shame-based restriction. Strength training deserves a specific mention here. It improves insulin sensitivity in a way that cardio alone does not. Because skeletal muscle is your largest glucose disposal organ, I recommend it to every PCOS patient. Second, metformin. It's not just a diabetes drug. It directly addresses insulin resistance in PCOS and has decades of safety data. This is a cornerstone medication in my practice for PCOS patients with metabolic concerns. Third, myo-inositol. I want to be transparent here. Inositol is not yet in standard clinical guidelines, but there's emerging evidence for its role in improving insulin signaling in PCOS. I discuss it with select patients as a complementary option, not a replacement for first-line treatments. Fourth, if androgens are significantly elevated and birth control alone isn't enough, spironolactone. It is effective for excess hair growth and acne. One critical safety point, spironolactone must always be taken with birth control. It can cause birth defects if pregnancy occurs while on it. This is non-negotiable. Birth control can absolutely be part of the plan, but it should never be the only plan. I want to speak directly to women who are trying to conceive, because the treatment approach is different and patients often don't get clear guidance on this. If you have PCOS and you're actively trying to conceive, birth control is obviously not the answer. Current first-line medication for ovulation induction in PCOS is letrozole. It has largely replaced clomiphene in this role, based on better live birth rates in clinical trials. Clomiphene, sometimes combined with metformin, remains an alternative. If those medications don't result in ovulation or pregnancy, injectable gonadotropins or IVF may be discussed with a reproductive endocrinologist. And again, metformin and lifestyle intervention remain important, even when trying to conceive. Restoring insulin sensitivity improves ovulation naturally and supports a healthier pregnancy. If you are a teenager watching this or a parent of a teenager, I want to flag something important. Diagnosing PCOS in teens is different than in adults. During puberty, irregular cycles and acne are very common and don't automatically mean PCOS. For a teen to be diagnosed, she needs both irregular cycle and evidence of elevated androgens, either on labs or clinically visible. Ultrasound of the ovaries should not be used to diagnose PCOS in teenagers because developing ovaries normally look polycystic. If you are concerned, see a physician who understands the adolescent diagnostic criteria and know that even teens who don't fully meet the criteria are at risk, but are at risk deserve monitoring and care. I cannot close this video without talking about mental health because the guidelines are clear on this and it's consistently undertreated in PCOS. Women with PCOS have significantly elevated rates of depression and anxiety. The combination of visible symptoms like acne, hair changes, and weight during years that are already challenging takes a real toll on self-esteem and body image. Disordered eating is also more common in this population. If you're struggling emotionally, please tell your doctor. CBT, cognitive behavioral therapy, has good evidence in PCOS for mood and body image. And sometimes medication is appropriate. Your mental health is part of your PCOS management, not separate from it. If you have PCOS or suspect you do, here are the specific questions to bring to your next appointment. Has my insulin resistance been tested? What is my fasting insulin and fasting glucose? Has my lipid been checked? Has my blood pressure been assessed? This should be done at diagnosis and repeated at regular monitoring. Has anyone looked at my metabolic health beyond just my period? Am I at risk for prediabetes or diabetes? If I am on spironolactone, am I also on contraception? If I'm trying to conceive, has letrozole been discussed? If I'm postmenopausal, has anyone connected my current metabolic health back to my PCOS history? You deserve complete answers, not just a prescription. PCOS is common, it is manageable, and the earlier you address it properly, the better your long-term health will be. But you need the full picture, and now you have it. If this video helped you, please subscribe. I post evidence-based endocrinology content every week. Share this with someone you know who has PCOS and has never heard of this, and comment below. What is the most frustrating part of your